Patients with psychogenic non-epileptic seizures, also known as functional seizures, have involuntary paroxysmal episodes that resemble epileptic seizures but without organic etiology. PNES are a dissociative phenomenon and understood as a conversion disorder. Many patients with PNES have a history of sexual, physical, or emotional abuse, or other traumatic or overwhelming experiences. PNES is a communication disorder in which distress is expressed somatically in a pathological way instead of a healthy verbal manner. The patient's body may seem to enact a communication of its own as the patient cannot or will not communicate directly about an overwhelming and unspeakable subject. Patients with PNES are frequently misdiagnosed and mistreated for epileptic seizures. Attempts to treat PNES with anti-epilepsy drugs and other interventions for epilepsy may cause harm. Accurate diagnosis may be delayed for many years. PNES may cause severe disruption of the patient's quality of life in terms of employment or schooling, as well as relationships and activities of daily living. Some patients with PNES have been accused of faking symptoms or malingering and stigmatized by healthcare providers, co-workers, family members, and others in society. Patients with PNES may have family histories of poor interpersonal communication and conflict resolution, with inherited codes of silence and shame concerning sensitive or traumatic subjects. Patients may be enmeshed in family relationships that are too close or controlling. In some cases, family members may also present a barrier to treatment or change for the patient. Patients with PNES may have post-traumatic stress disorder as a comorbidity. PNES may be described as an orphan disorder, with no one discipline taking responsibility. Interdisciplinary collaboration is needed. Neurology, psychiatry, and other therapies may be needed at different stages of treatment over a lifetime of care. Narrative medicine visits draw out the patient's narrative of illness or injury and treatment in the context of their entire life story. NM is patient-centered and open-ended, with focus on exploring topics the patient needs to discuss. NM sessions are interactive and dynamic, responding to topics and issues raised by the patient in a guided conversation with a collaborator who listens attentively. There is no script or checklist for NM sessions. Unstated or silenced concerns may be voiced, and new insights may be discovered by the patient. NM sessions are not confrontational and may take unexpected turns. An unhurried context of trust where the patient is respected can encourage the patient to communicate about difficult history and conditions. It may be helpful for an initial session to include basic questions about the patient's condition or medical issues, the patient's sources of strength and support, new insights or awareness during treatment, and hope or goals for the future. A patient with PNES who constructs a story about personal trauma or overwhelming stress can discover a narrative antidote to the communication disorder and inhibition of PNES. Some patients with PNES may have been warned not to tell their story, or shamed into silence by family members, friends, or colleagues. Some patients may have been deeply hurt by traumas or past efforts to tell their stories that were not believed or well received by others. Some patients may now feel overwhelmed by past traumas, current stress, or future challenges that seem impossible, and they may feel equally overwhelmed by the prospect of communicating their pain and distress. But the patient with PNES can become the teller of the story, who discovers hope by putting the unspeakable into words. Old taboos and codes of silence can be let go as the patient collaborates with an attentive NM provider. NM sessions encourage patients to communicate more effectively about their unspeakable distress and reclaim their lives from the communication disorder of PNES.